will do that right now while I'm still feeling cute with my heels, but when my feet hurt, I'll put the stand in the middle. And so, did we have a question? Did I see a hand for a question? Sting.
I wanted to know if the healthcare reform bill, is this realistic? Do we have enough healthcare providers to answer the demand? For instance, for women, we have to see special tests, right? We have to go to special doctors to get certain things done. Right now in Connecticut, it's a 6-month waiting period for me to see a specialist, and I have pretty good insurance. Is this plan realistic? Do we have enough people to answer the call?
Alex, you want me to take that? Who did you address it to?
Oh, everybody, I suppose.
The answer is no. And again, I'll give you one political statement. I really wish our president had been more hands-on involved in this, because the people did not elect Pelosi or Harry Reid. People elected the president. And my only criticism of the president is that he hasn't been more involved in saying what he wanted here, because he is who we, the people, elected. Having said that, nobody is talking about the provider shortage. I'll give you an example. Whether you believe the numbers or not, if there's 45, 46 million people proposed to be uninsured, as Gary was talking about 65% of those have had health insurance offered to them in the last 18 months, but they couldn't afford it. Putting that aside, the current Baucus bill would still leave 24 million people uninsured through the current bill. So now we're going to deal with 22 million people. If you take 22 million people that probably are not utilizing the system because of the lack of insurance, you now let them access the system, I instantly need 16,000 new medical doctors. Now, only 6% of the people in medical residency programs in the United States are going into primary care. Where am I going to get 16,000 new medical doctors? I have here a report that, if anybody wants it, also talks about in Connecticut, published last year, physicians and physicians recruitment. And it says that the length of time to recruit new physicians range from an average of 7 months for emergency doctors, for 2 years for orthopedic surgeons, urologists, neurologists, neurosurgeons, and OBGYN. So the answer to your question is nobody is addressing the provider equation inherent in taking 24 million additional people to be insured. No political statement at all. Nobody is addressing that, as they should.
We have seen in cancer treatment, there was a major reform that was passed in 2003. A shorthand term for it is Medicare, the MMA, Medicare Modernization and Improvement Act. That one bill changed dramatically, among other things, how cancer reimbursement was handled. And the long and short of it is oncologists are paid for the drugs that they use when they're treating, and they also are paid for their professional services. The goal of that was to drop the margins that were on the drug. But what Medicare and CMS did not recognize is that the margins that were on the drug were paying for services because the professional services were not reimbursed at an appropriate level. So when they squeezed that balloon, they dropped one piece of it, and the other piece they didn't address. So what we saw before 2003 was sort of if it ain't broke, don't fix it. It was broken, but the way that they chose to fix it ended up having consequences. Now Medicare, Part A takes care of hospitalizations. Part B takes care of treatment that's done in the outpatient setting, in the physician office setting. Medicare Part A and Part B do not talk. And so that's one of the problems when you start to look at healthcare reform. Because in the private world, getting back to the common sense, if you're not able to receive care in a community office and you need to go receive care in a hospital setting, what do you think the difference in cost is going to be? There's a massive difference in overhead. Business, common business, if you're paying for a smaller building with a smaller number of nurses versus a large building, there's going to be a cost difference. Medicare does not recognize that. Part A says, it is what it is. We're paying for the services that are delivered. Part B says, don't ask me for any more money, and if you end up having to not pay here and send someone to the hospital, it's no skin off my back. So one of the challenges when you're dealing particularly with the federal government with healthcare reform is their inability to recognize that. So when I go back to my story, before the healthcare reform in 2003 that modified the oncology payments, there wasn't a Medicaid patient in Connecticut or virtually in most of the country that could not get cancer care when they needed it. There were ways of doing it. And now we're seeing a dramatic shift where there are changes in weights. People end up, we saw down in the southeastern part of the state, the Norwich area, when the office couldn't afford to pay for the treatments because of the changes in reimbursement, that the patient had to go to the hospital. The hospital said, we have 3 chemotherapy chairs. So the weights increased. Now, when you start to talk to insurers or to the federal government, that is not perceived as an access to care problem because the patient still has a place where they could get care. It may take 4 months longer, 4 weeks. Obviously, cancer treatment delays do have implications for medical care and in a lot of other specialties as well. But that's considered the difference between Walmart care and Nordstrom's care. And we actually have the administrator for Medicare in Connecticut and New York right now is now issuing policies that say we cannot afford to pay for treatment done a certain way, and the reason that you have to give us a medical necessity for why you're doing it this way, if you want to do it the more costly way. But the reasons for medical necessity shall not include patient financial hardship. So if this forces a patient to go and buy an outpatient drug with the donut hole that we've all heard about, particularly for Medicare patients, that doesn't mean that the doctor is then able to give the other type of treatment. They have said explicitly patient convenience is not a reason for changing the way that you're treating because it's going to cost us more money. We don't care if it puts you through a greater inconvenience. We have seen cancer patients have to go now from getting care in a 3-hour setting in the office to now having to take their transportation to a hospital setting. Then they run into the nurse shift changes. So now their treatment, instead of taking 3 hours, may take 6 to 8 hours. They've lost access to their transportation, or maybe they were having aids or some kind of transportation help to get them home, and now they don't have a ride. But in the terms of the federal government system, that is not justification for them then paying for the office. So one of the challenges is if the care is accessible in some way, even if it takes months, days longer, and you need to jump through a lot more hoops to get it, then that is not considered a hardship. And that's frustrating. It's very frustrating for the physicians and the nurses and the hospitals that are trying to provide the care, because their gut is, this isn't the way it should be. I mean, Dawn needs treatment. I want to be able to give her what she needs. But I don't want to have to turn to her and say, I'm sorry, you can't get that because your insurer has said that's not the way we're going to pay for it. But that's the reality that we're running into. We have seen at least 3, if not 4, physician offices completely close here in Connecticut in the last 2 years because of this change of that MMA. I'm seeing very good doctors retire early, so they're no longer there to provide care. So the shortage is very, very real, and I see it in terms of the faces that aren't there right now.